Welcome everybody, good afternoon. I'm really happy to be here and I'm so excited to have this collaboration between the Murphy Institute, the School of Medicine, and the School of Public Health and Tropical Medicine. So what are we here to do? We're here to talk about medical workforce issues, right? And first off, let me tell you a little bit about what's going on with the Murphy Institute. The Murphy Institute is concerned about public policy, but public policy's impact on the economy. That's what we're considering to be political economy. And as you think about the areas of public policy, you can think about housing policy, you can think about environmental policy, but what we're here today to talk about is health policy and health policy's impact on the environment, at least from our perspective. And we are really happy to have everyone here, and we'll have an introduction of the Admiral coming in a minute. So I think our Dean Levine will talk a little bit about his school, and then Dean Ham will finish up.
Hello and good afternoon. Okay, if I call, you do what? Respond. All right. So you know what you're supposed to do, right? So good afternoon. Come on, we've got a great program for you today. So let's get a little energy. I have the honor of serving as dean of this. I have the honor of serving as dean of the School of Public Health and Tropical Medicine at Tulane University. I've been in this role for 4.5 years. We are the first school of public health established in the United States. I will point out that there are 2 other schools that claim to be the first. Okay. Harvard was founded in 1913, and Johns Hopkins was 1916. We were 1912. I'm not quite sure how they can be the first, but we are the first. Not the most important thing, but it is a thing. It's our thing. We're pleased to be in partnership with the School of Medicine and the Murphy Institute on this important topic of the healthcare workforce, which is, of course, critical to us. Those of us on the academic side of public health and medicine have a daunting challenge, that is to educate the next generation of healthcare workers, which is an extremely complicated thing to do in a field that is so rapidly changing. There are positions now in C-suites of healthcare organizations that didn't exist just 10 years ago. Chief population officer. Think for example. So we don't know what those new positions will be in the future, or how best to educate people. This is a challenge that we're constantly working on, and a challenge that we're looking forward to meeting as we move into this new uncertain future. And on that note, I will end my remarks, and I will turn it over to my colleague, Dean Ham from the School of Medicine.
Well, when we contemplated this symposium, healthcare shortages we're a little bit on the horizon, and I think the 3 of us forming the Murphy Institute, School of Public Health, and the School of Medicine thought, well, this is a great topic, but it's turned out to be even more timely today than it was even a few months ago. I think what's become clear now. Admiral Levine may get up here and say, no, it's all, we've got it covered, it'll be solved in a couple of months, but is that it's likely to be persistent. And so we've got to look for new ways to approach it. I don't know what those approaches will be. One of the things that, really was so fortunate about us having this is we are fortunate at Tulane where a good deal of collaboration takes place, and for such a symposium to span between the Murphy Institute, the School of Public Health, and the School of Medicine, and from my perspective, is just fantastic. You could not imagine a better congealing of forces to think about it, and then to help plan, help be involved in how we address this important topic. And we really have remarkable people here to help address this. So this is a very timely topic. The School of Medicine is proud to be involved. Thank you for that. Thank you for being here. I want to thank our speakers. Now, I'm not quite sure of one logistical thing. I'm not sure if I introduce Dr. Levine. I introduced Dr. Levine. Good. I had practice yesterday. And so most of this I'll remember from yesterday, but it's a real pleasure. It's doubly fortunate. Not only is she such an honored national expert on sort of all matters of health and public health, but she also is a Tulane alumnus. She went to medical school here. She went to Harvard for her undergraduate. She then went to Einstein in New York to do her pediatrics and then adolescent medicine, and began her work there, looking at the intersection of a variety of things: pediatrics, adolescent medicine, underserved communities of all types, and she's continued that work. She then, into her career, went to Hershey, Pennsylvania, at the medical school there, and had a prominent academic career, papers, leading first the adolescent medicine section, vice chair of the department, I think some school-wide appointments as well. Then she was nominated for two sequential posts in state medical leadership. The first was the physician general, I think, of the state of Pennsylvania. And then became the Secretary of Health for the state of Pennsylvania. Two important posts. I actually didn't know of Dr. Levine till then, despite her being an alumnus, but began to be widely recognized, and in fact was so widely recognized that, as you all know now, she was nominated by President Biden to become the Assistant Secretary for Health and Human Services, was unanimously confirmed. I think that's correct, or near unanimously, or she was...
That was in Pennsylvania.
Pennsylvania.
The federal government wasn't quite as generous.
Well, I knew as I was saying this, I was just sort of, gosh, am I shocked? Whatever happens. I don't even think we could get Mother's Day approved these days. But anyway, has been serving that with distinction, and obviously has brought a lot of attention to a lot of different issues. Among those are COVID, and long COVID in particular, in this era. She continues to advocate strongly for underserved minority populations of whatever stripe, whether it's racial, ethnic, gender, sexuality, and has been a strong advocate for that. But a strong advocate for everything. Mental health has been another something that's been woven into her career from early on as very appropriate. Been elected to the National Academy of Medicine, is also a fellow of the Pediatric Society, and many other honors, both now and I'm sure She also is a noted speaker. Just as a small FYI, the School of Medicine was fortunate to have her talk at our graduation some 21 months ago or so, 23 months ago, 22 months ago, something like that. Anyway, where she gave a wonderful and memorable address, inspiration to our young doctors going out. So it's a real pleasure to have Dr. Levine, Admiral Levine, rather, here. Thank you very much.
Well, thank you for that welcome, and thank you for that introduction, Dean. I'm really pleased to be here. I'm going to be speaking about a number of different things about healthcare policy and as well as workforce. I'm delighted to be back in New Orleans. As the Dean mentioned, I am an alumni of the Tulane School of Medicine, and brings back a lot of memories being back here in New Orleans, including the wind and potential rain. But of course, I graduated 40 years ago in 1983. My path has taken many unexpected turns from my days at Tulane, and I am truly honored to stand before you today as the Assistant Secretary for Health and as a 4-star Admiral leading the United States Public Health Service Commission Corps. Medical and public health careers are certainly interconnected, and they both have lasting impacts on people's lives. And I have always felt gratified by my medical career, starting here at Tulane, because all we have done as physicians and other medical professionals is try to help people, try to help patients, teach students, do clinical research, develop programs. And that's what I've tried to do in my public health career, of course, with that broader public health perspective, that broader brush, first in Pennsylvania and now throughout the United States. So I'm excited to share some of the work that my office is doing, the work of the Office of the Assistant Secretary for Health. Our vision is healthy people, healthy communities, and a healthy nation for all. And the for all is key, because health equity is key to everything that we're doing. We are leading key policy initiatives to advance health equity in its programs, protect and secure access to reproductive health care, advance LGBTQI+ equality, address climate change in health, which I spoke about yesterday, environmental justice, and prevent, detect, and treat long COVID. The Chief of Staff of Health and Human Services and the Secretary often call our office the connective tissue of the department. Personally, I was hoping for the beating heart of the department, but what I got was connective tissue. But we are the conveners. We are the people that draw together different divisions within the department and within the administration to deal with these health equity issues. Achieving health equity requires valuing everyone equally, with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the social determinants of health, and to eliminate disparities in health and health care. Of course, the social determinants of health are the conditions in the environment where people are born, live, work, play, worship, and age that affect a wide range of health functioning and quality of health outcomes. I want to note that Dr. Karen DeSalvo, who will be speaking this afternoon, was the Acting Assistant Secretary for Health under the Obama administration, also a graduate of the Tulane College of Medicine. And she developed the concept of Public Health 3.0, which really brought together all of the issues of the social determinants of health. These non-medical factors have a strong influence on one's health and well-being, and they uniquely impact my priority areas, including access to reproductive health, LGBTQI+ issues, and long COVID prevention and treatment. So we first are exploring many different policy options and actions to protect and secure reproductive health care access. The work that our Office of Population Affairs does includes our Title X family planning program. Title X provides family planning for teenagers and for indigent women. I actually was trained in a Title X program in 1987 in my fellowship in New York City, and I ran a Title X funded program at the Penn State College of Medicine in Hershey, Pennsylvania in 1996, starting in 1996, where I was told I didn't need that program because kids didn't have sex in Hershey. Who knew? But they did, actually. And so our Title X program was particularly important. Last year, our continued focus on rebuilding the family planning network issued nearly $3 million in Title X grant awards. The President's 2024 budget, which was recently released, proposes $512 million in Title X family planning program to meet the increased need for family planning services in the face of the Supreme Court decision. Last year, I have traveled across the United States and heard from people from Albuquerque to Chicago to Camden, New Jersey, and really throughout the country who have cited an increase in out-of-state patients and how important Title X is to them. Many cannot afford to get care anywhere else. This program saves lives, this program improves health, and it makes our community safer and healthier. I co-chair, along with Assistant Secretary for Global Affairs, the Reproductive Health Care Access Task Force, which was formed 1 year ago to develop domestic and global policy responses to the unprecedented number of laws aimed at undermining sexual and reproductive health care. And this effort is even more critical now following the Supreme Court's decision. At HHS, the Secretary Becerra and myself, we have an unwavering commitment to protecting access to the full range of reproductive health care services that women need, including abortion care. HHS has initiated concrete action to protect access to these critical health care services, as well as the privacy and legal rights of patients and providers. But what we see now, as we talk about the social determinants of health, is that the political context of the state where people live is itself a social determinant of health. The state where you live and the political and legal construct in that state is itself now a social determinant of health. From day one, President Biden, Vice President Harris, and Secretary Becerra have been champions for the LGBTQI+ community. Last June, President Biden signed an historic executive order advancing equality for LGBTQI+ individuals. Our department has historic deliverables, including safeguarding youth from the harms of conversion therapy, addressing discrimination and barriers faced by LGBTQI+ children and families in the child welfare system, in the juvenile justice system, strengthening support for LGBTQI+ older adults, and advancing health equity for intersex individuals. We are working diligently to fully implement the President's executive orders. An example of our efforts includes the Ending the HIV Epidemic in the United States initiative, EHE. This bold plan aims to end the HIV epidemic in the United States by 2030. It leverages scientific advances in prevention, diagnosis, treatment, and outbreak response, and coordinates many successful programs across the country, and specifically looking at the cities and the counties where new HIV cases is most prevalent. I remember in my residency program starting in 1983 in Mount Sinai, I saw HIV at the beginning in New York City. Now in pediatrics, we actually saw newborns and babies with vertically transmitted HIV, and then their mothers who developed HIV, AIDS, and tragically passed away. In adolescent medicine, I saw more and more teenagers with HIV, colleagues and friends with HIV, who in the 80s all tragically passed away. We have so many medical miracles now, what I would consider medical miracles from the NIH and other research programs, such as PrEP, such as U=U and antiretroviral treatment therapy. But we're still not there yet. We're still, from a health equity point of view, not getting those quote-unquote medical miracles to the people who need them most. And so that is the purpose of EHE, ending the HIV epidemic. And I was there at the beginning, and I am committed to be there at the end of the HIV epidemic. I recently announced a change in the United States Public Health Service Commission core medical standards to end the exclusion for people living with HIV. Now people living with stable HIV can join our esteemed Public Health Service Commission core, as well as those with stable hepatitis B. So we are committed to doing everything we can to ensure a healthier, more equitable future for all. But even with all of this progress, the federal government cannot do this alone. It requires leaderships at all levels of government and all aspects of medical care. And one aspect where this is not being brought to bear in too many states in this country is in terms of gender-affirming care for transgender individuals, especially vulnerable transgender youth and their families and their providers. As Assistant Secretary for Health, I am urging us to base medical care on the facts. And the facts are that gender-affirming care is medical care. Gender-affirming care is mental health care. Gender-affirming care is suicide prevention care. It improves the quality of life. It saves lives. It is based upon a decade or more than a decade of study. It is a well-established medical practice with a well-established standard of care through the World Professional Association for Transgender Health, published just this last September of 2022. Based upon the research and based upon the evidence, and all respected medical organizations agree, from the American Medical Association to the American Academy of Pediatrics to the American Psychiatric Association, the Endocrine Society, the Pediatric Endocrine Society, and more, that gender-affirming care is medically necessary, safe, and effective for transgender and non-binary children and adolescents. Those who attack our community are driven by an agenda that has nothing to do with science and nothing to do with medicine. And I feel that we all need to stand up and support the science behind this. As a nation, we continue to make strides in the fight against COVID-19, but we need to shine a light on the impacts of long COVID. And long COVID, the coordination of the long COVID response at HHS and across the administration is driven through my office. Estimates vary, but anywhere between 7.7 to 23 million Americans have developed long COVID. So we need to educate the public and distill misinformation about this. And we need to educate our colleagues in medical fields and public health fields about long COVID. Long COVID is real. Even the wind agrees. Long COVID is real. But it might not represent one condition. It might be a set of infection-associated conditions that have many potentially overlapping entities with perhaps different biological causes and different risk factors and outcomes. So the research about this is absolutely critical. The research through the NIH, through the Recover Project, through the CDC, through the Inspire Project, research at the VA, and in our great academic medicine institutions. This is a health equity issue in multiple senses. Adults suffering with limited economic resources have difficulty finding effective treatment, navigating health-related workplace and employment issues, and finding understanding even among our medical community. And so we have to address these issues. My office has recently released 3 reports. The National Research Action Plan on Long COVID, released in August of 2022. The services and supports for longer-term impacts of COVID, also in August 2022, and last fall, the Health Plus Long COVID report. But these are just one part of our broader whole-of-government response. I spoke yesterday at Tulane about the impact of climate change on health, and specifically the impact of climate change on health equity. More than 200 medical journals have asserted by late 2021 that climate change is the top threat to public health in our nation. It impacts us on many dimensions, physically and mentally, but it's also particularly damaging to vulnerable communities that are victims of long-term discrimination and underinvestment. We have climate change, and I don't have to tell you from New Orleans, to extreme storms that are exacerbated and stoked by climate change, to sea level rise happening 30 to 50 miles from this door, to extreme heat, which you see in New Orleans, but I have seen in Seattle and New York and really across the country and across the world. Powerful wildfires and the smoke from those wildfires and more. Vector-borne diseases, which I know you study at Tulane and at the Public Health School and Tropical Medicine School. So the list is long and worrying. And crises don't wait their turn. We've seen weather-related issues shutting down COVID-19 testing and vaccination sites. So we have to build resiliency into the healthcare system to the health impacts of climate change. And we have to deal with the carbon footprint of the healthcare industry itself. The healthcare industry actually accounts for 8.5% of US carbon emissions. 8.5%. So to reach our goal of cutting carbon emissions 50% by 2030 and to be carbon neutral by 2050, then we have to engage the healthcare industry writ large, not just hospitals and health systems, but pharmaceutical companies, the supply chain, and more. So we have opened 2 new offices, the Office of Climate Change and Health Equity, which we affectionately call OCHE, and the Office of Environmental Justice, its sister office. And they report to me, and we coordinate together. We have bold initiatives for this. We have the creation of the Climate and Health Outlook, which is a periodic forecast of how extreme weather events will impact the healthy people, the people of the United States. The expansion of LIHEAP, the Low-Income Home Energy Assistance Program, which will provide funds not only for heat, but for cooling right here in Louisiana. The launch of a decarbonization primer for hospitals and health systems, and the launch of a federal health system learning collaborative. Also, we invite the private sector to join us with a White House HHS healthcare sector climate pledge. And the pledge is to work to decrease carbon emissions 50% by 2030, be carbon neutral by 2050, to improve the resiliency of the hospital and healthcare system or other organization to the impacts of climate change, and to start to deal with the impact of of other aspects of the health sector, including the supply chain. We have had more than 100 organizations representing over 1,000 federal and private sector hospitals, representing about 15% of the U.S. hospitals, but others, again, suppliers, pharmaceutical companies, insurers, and other health sector stakeholders. We provide technical assistance resources so that they can take advantage of, and we have reopened the pledge due to popular demand. Health systems can now sign on to reduce emissions and build resiliency. And we reinforce this with a public-private partnership and cooperation with the National Academy of Medicine's Climate Collaborative. In addition, Congress passed the Inflation Reduction Act, which really creates an unprecedented opportunity for health systems to make investments in this issue, and also to seek billions of dollars available to transform this industry. One important lesson of the COVID-19 pandemic is that we are all interconnected, and we need to ensure a healthier future by eliminating health disparities and promoting health equity. But the other importance is the importance of public health itself, the importance of public health. Public health is the center of the universe right now in terms of the healthcare challenges that face our nation. I used to say the center of the universe was Brooklyn, but actually it's public health. And we must ensure that local, state, and national and international public health authorities have the resources, the workforce, and the IT capabilities needed to protect the health of our nation and the world moving forward. So in terms of workforce, for the medical and public health workforce, the Biden-Harris administration is committed to making robust health workforce issues to make communities healthy. The American Rescue Plan invests in equipping communities and public health workers with the skill sets needed to provide effective community outreach, increase access to care, and assist individuals with critical prevention and treatment services. The Bipartisan Safer Communities Act helps primary care physicians meet families' mental health needs. HRSA has issued grants to support making mental health part of the training in primary care clinicians, with a specific focus of the mental health needs of children and adolescents. Nurses are a critical part of our healthcare workforce, and we are also committed to growing the next generation of nurses, ensuring the education and training that they need. So despite the heavy toll that it has exacted, COVID-19 has reminded us of a fundamental truth, that we truly need each other, that our happiness and our very survival depends upon our connections to one another and our connections to the community. And that spirit of community is what makes our country great. And it's what we need now more than ever. We know that there are many groups that face unique and increased risks. We must work to close disparities in access and outcomes, eliminate bias and discrimination, and address the systemic barriers, including the barrier of systemic racism, that have contributed to historic inequities. All Americans deserve care and services that are timely, affordable, accessible, equitable, and high quality. These are our family members. These are our friends, our neighbors, our coworkers. These are our students. As a nation, we can do better. We must do better, and we will do better. So thank you very much for having me today. I'm looking forward to answering everyone's questions. Thank you.
So at this point, I'm going to help in moderating any questions for the Admiral, meaning that she's free to answer any that she wants, and then those she doesn't want to answer, I shall nix. So let that be your guide. Does anyone?
Yeah. Let the games begin. Yes, sir.
Are you planning for the next epidemic?
Yes, there are significant plans at HHS and at the White House for the next potential epidemic and pandemic. So there is a lot of work being done in terms of public health preparedness through ASPR. ASPR, which is Preparedness and Emergency Response Office, has now become its own operating division. It is now separated from just the Secretary's office, and they have significant funding in the 24 budget for workforce, for the National Strategic Stockpile, and more to help us prepare. In addition, actually there was legislation last year signed by the President to set up a pandemic preparedness office at the White House, and I know the White House is working to set up that office as well, and so we all need to work together to prepare for the potential of another epidemic, another pandemic. But it's not just the federal government that needs to prepare. So as the Dean mentioned, I was previously the Secretary of Health of Pennsylvania, and I was the Secretary of Health of Pennsylvania during COVID-19. They are the two hardest years of my life. One was being chief resident of pediatrics at Mount Sinai in 1986, and the other was the 2020 and navigating Pennsylvania through the COVID-19 pandemic, especially towards the beginning where we had no tools, right? I mean, you need medical countermeasures, vaccines, treatments. We had none of that. All we had were the public health tools of containment and mitigation, which proved to be extremely unpopular, but absolutely necessary. So public health works best when there is collaboration between local health departments, state health departments, and the federal government in public health, involving, of course, academic medicine and more. So that's what we need to build. We need to build the workforce for that, the medical workforce to prepare, but also that coordination in terms of data and in terms of IT to be able to work together to best cope with the pandemic, and working with the WHO and international authorities as well. Yes?
What strategies or policies would you recommend for helping the healthcare supply hospitals become more? Thank you.
Yes.
Just wanted to know what policies or strategies you might recommend for making healthcare supply in hospitals more environmentally sustainable.
Absolutely. So through our Office of Climate Change and Health Equity, we do offer technical assistance to hospitals and health systems or other companies that are willing to take this journey. So there are many different aspects. So let's think about in a hospital. One is obviously the physical plant and the energy supply and how the energy is maintained for the physical plant. But as if not more important, let's think about all of the materials used in a hospital or health system. There's an amazing video we saw at the National Academy of Medicine meeting, which was made in the EU, where a woman who was a public health professor who had an operation, a basic operation, laid out all of the different materials that were used in her operation, and it filled the gym. And it was just a routine, basic type of operation. But for her time in the hospital, it filled the gym. So we have to deal with the sustainability of these, the plastic content of all of these, and then we have to deal with the supply chain. And what is the carbon footprint of the supply chain in terms of how these materials are built, to how they're transported, to how they're discarded. So many different complex issues, but we need to start someplace. And so we need to educate medical providers, public health students and providers, and medical providers of all types about these issues. And then we need to work with the hospitals and health systems to accomplish it. Yes, sir.
I have a question. Those of us on
Yes.
For those of us on the academic side, what should we be thinking about adding to our training programs to ensure that we are meeting the needs?
Absolutely. So I have a number of different responses to this. So I think that that public health students and medical students, but I'm also talking about nurses and other medical providers, need to learn about public health. I think that medical students need more education about public health. I know how challenging this is because the curriculum is already packed. But with COVID-19 and the climate change issues that lay before us, I think they need to know the basics of public health, the basics of epidemiology, so that they can help us. They can help interpret the messages coming from federal, state, and local health departments, and then teach their patients about that. And I think we've seen challenges because of their lack of sophisticated knowledge about these issues. I also think that all of the students that we talked about need to learn about climate change and the impact of climate change on health, the impact of the things we've been talking about, extreme heat, sea level rise, forest fires, vector-borne diseases, and more, which are afflicting our nation, but really across the world. I also think that medical students, especially in depending upon what field they're going into, need more education about mental health. So I'll give you an example about pediatrics, and I have spoken to the American Academy of Pediatrics as well as the residency training program directors for pediatrics, as well as the AAMC and more, that, I mean, the mental health challenges of our youth are almost overwhelming. And we will never have enough board-certified child and adolescent psychiatrists to see every young person who needs a mental health evaluation of some sort. Or if they need medication as a teenager, if they need fluoxetine 20 milligrams a day. Pediatricians are going to have to do that. Family physicians are going to have to do that. I think that public health students need to learn basics about mental health so they can work on policy about that, because the mental health challenges that we're facing, both in terms of traditional mental health issues and the addiction crisis and overdose crisis facing our nation, means that all physicians need some type of grounding in this more than they have, both in medical school and in their training programs. Yes?
All right, hi.
Hi.
My name is Angelle. I'm a PhD student at Tulane Med, and I often spend a lot of time going to the Capitol to advocate just with different legislators,
Great.
everything from like vaccines to climate. And I just was curious, can you speak a little bit more on how your office works either with the states or with legislators when we have like this huge
Sure.
onslaught of, anti-trans bills
Sure.
and then access to reproductive
Absolutely.
rights? Yeah.
So, I think it is absolutely necessary for us to work in the federal government on these issues. And we do. So we work with stakeholders across the country. We work with legislators that are willing to talk to us about these issues. And we advocate about the science behind the medical science behind the need for women to have access to the full range of reproductive health treatments that they might need. And I talked about the need for gender-affirming care for adolescents and young adults and older adults. And the evidence behind that, as outlined in the standards of care by WPATH. But my advocating for that, here and there and everywhere, is not sufficient. It is necessary, but it's not sufficient. And not only I do, the secretary, we all do. We need state and local health departments to do that. We need physicians and PhDs and public health students to stand up in their local communities and in their states to do that. We need to do this school board by school board and city councilor by city councilor. And to do this in the state legislators as well. We have encouraged, the American Academy of Pediatrics has stood up, ACOG, the American College of OBGYN, American Academy of Family Physicians, and others. We need organized medicine to stand up, and we need to counter the politically motivated laws that are impacting women and and LGBTQI plus people in the country.
Thank you. Kind of shifting gears.
Sure.
So the pandemic really hit Native American communities hard, especially in
Absolutely.
reservation lands. I'm curious what you see going forward as perhaps the opportunities that increasing awareness has created to advance equitable health access and quality of care for Native communities?
Absolutely. So I had mentioned that health equity is central to everything that we're doing at the Department of Health and Human Services under Secretary Javier Becerra. Health equity is fundamental to everything that we're doing. So it's not that we do health equity on Friday afternoons. Health equity is foundational to everything that we're doing, and that includes, but not exclusive to, but includes the African American community, the Latino community, and the American Indian Native Alaskan community. We have a very dynamic director of the Indian Health Service, Director So, who's a member of the Navajo Nation and has worked in this area for many, many, many years. I've had the pleasure of meeting her and talking with her and networking with her. We have significant increase in funding in the 24 budget for the Indian Health Service to be able to expand their services. And we need to also work, for example, our Public Health Service Commission Corps officers. We have about 1,000 officers who work in Indian country and who work at the Indian Health Service in throughout the country and in Alaska as well. And so this is really one of the missions of the Public Health Service is to work with vulnerable, underserved communities. So I think that there's a lot of efforts to do that. But it also comes down to the social determinants of health. So, I mean, from that perspective, again, under the leadership of Dr. DeSalvo and Public Health 3.0, economic opportunity is a health issue. So economic opportunity I never knew that it's called Indian country, and I used to think that that was somehow, I shouldn't say that, but that's actually the term that's used in the federal government. So, economic opportunity in Indian country, the environment in Indian country, the heat-related issues, the issues up in Alaska in terms of the Arctic, which is suffering most from climate change, housing, nutrition, transportation issues. All of these issues are actually health issues. And so you can see how the administration's vision and mission across the administration with all of the different departments impacts health, including for American Indians and Alaska Natives.
Thank you. So oftentimes the healthcare profession is viewed as providers and patients. One of the lessons of the COVID pandemic was underscoring the need for and the importance of self-care. And so I was wondering, as the husband of one nurse and the father of a soon-to-be nurse, what your office and others are doing to address issues such as burnout and other things, and what local hospitals or academic medical centers can do to address that issue as well.
Absolutely. So the significance of burnout in medicine and public health is very significant. I can't tell you, well, you all know how taxing the last 3 years has been on our medical providers at all levels, at outpatient facilities and hospitals with the COVID-19 pandemic, as well as the mental health crisis, the overdose crisis, these compounding crises, the climate change, coming, and it is very significant. And so it is something that we're looking at carefully, and it is one of the things that our Surgeon General, Vice Admiral Vivek Murthy, is concentrating on. And he wrote a report about this this year, in 2023, and he speaks about it all the time. And he is, outstanding speaker and public health official, and this is one of his issues to talk about. So, I think that one of the things is the workforce issues that I spoke about briefly, but that you're going to be talking about later today, is we need to buttress the workforce at all levels in our medical system and in our public health system. We need to churn out more students. We need more public health masters and doctoral students who go into local, state, and federal public health. We need more primary care physicians. We need more primary care physicians that know how to treat basic mental health needs. We need more nurses. We need more mental health professionals, and there are many different programs throughout HHS, particularly with HRSA, which deals a lot with workforce issues, to supply that. Loan repayments and more for primary care, for mental health. We need more addiction specialists at all levels, from physicians who specialize in addiction medicine down to peer counselors. I know CMS is working on the reimbursement for all of those different services as well, and there's a lot of money in the 23 budget to support that. So I think that we need, probably most of all, to acknowledge the burnout. There was an article in the Washington Post, I believe yesterday, about burnout among pediatricians, right? I'm a pediatrician, who have dealt with COVID, who have dealt with the triple-demic, which we don't usually talk about, but COVID, flu, and RSV over the last year, especially last fall and into the winter, and the mental health issues that our youth have. If you look at the YRBS that came out this year from the CDC, the Youth Risk Behavior Survey, it outlined the significant challenges in mental health that we have with our youth. So we are working to supply the workforce for that and to buttress our public health system and our medical system against the challenges that we face.
Could you stand one more question?
Sure.
All right, so we have time for one more. Thanks.
Thank you very much. And since I'm the last one, I'm also going to thank you. Thank you for doing this. But I wanted to go back a little bit between basically talking about the interplay between economics and health equity.
Yes.
And one of the issues with health equity in general is that lower income, non-college individuals tend to have an issue about getting treatment and adhering to treatment, even if coverage is not an issue. And so going back to examples that you mentioned, if you think about the HIV treatments or even long COVID,
Yes.
you have problems that sometimes, even if coverage is not an issue, those people do not have necessarily the ability to take time off of work. And
Yes.
basically the drug side effects are so large for them that they tend to be more physical jobs that they simply cannot do it.
Yeah.
And so I basically wanted to ask how you're approaching this issue from the perspective of, your department, when it's also simply not simply, but it's also simply a question of unemployment benefits, for example, and really a much wider sort of involvement from the state and federal governments from that
Yes.
perspective.
Well, the social determinants of health involve every department. So unemployment benefits would be in the labor department, but that's how the social determinants of health work. So those issues that might deal with the labor department is a health issue. So first of all, coverage is critical, because if they don't have coverage, it makes everything 10 times worse. And so that is why the President and the administration are such strong supporters of the Affordable Care Act, such strong supporters of states expanding Medicaid under the Affordable Care Act. There are too many states across the country that have not expanded Medicaid to populations and communities that could have health care coverage under the Affordable Care Act, but they just don't do that for political purposes. Also, CHIP, as well as the marketplace. So many different options, but we need to work to close those gaps so that everyone has access to healthcare coverage. But that's necessary, but as you pointed out, that's not sufficient. So we need to teach all of our students in terms of healthcare and public health communication, and how to talk to patients better so that we can do interventional motivational teaching about different issues. Also, I think that given the issue in terms of work, telehealth has a lot of opportunities. And I think that we've learned a lot about telehealth in the COVID-19 pandemic. There's tremendous potential there. That's its own health equity issue, because you need to have a phone or some type of smartphone. You need broadband coverage. Many areas in our country don't have broadband coverage or don't have cellular coverage, and so all of this is overlapping. But I think that we can improve things through various aspects of telehealth.
Well, thank you.
Thank you.
That's
Thank you
all I
very
can say.
much.
Thank you very much.
Appreciate it.
All right, so before everybody runs out, there's two announcements to make for you. Number one, I wanted to acknowledge Martha Murphy of the Murphy Institute. Yes, that Murphy. And want to say thank you for helping putting this on. And in addition to that, before we take a break, we have a video that hopefully is primed from Senator Cassidy. So I shall get out of the way, and hopefully this thing will play.
Hello, I'm Senator and Dr. Bill Cassidy. Thanks for attending Tulane Symposium on Healthcare Workforce Shortages. The COVID-19 pandemic strained healthcare. It placed a huge burden on healthcare workers. I'm told this shortage particularly affected rural and urban underserved communities who already had poor health outcomes before the pandemic. Now, I'm the new ranking member. Ranking means you're not the chairman because Republicans are in the minority. I'm the new ranking member of the Senate Health, Education, Labor, and Pensions, abbreviated the HELP Committee. Addressing the current healthcare workforce shortage is one of our priorities. Last week, the committee held a hearing on healthcare workforce shortages and discussed potential solutions to fill the gaps. Now, there's different things we can look at. For example, upskilling nurses, the LPN becomes the RN. Helping the EHR work better for both the patient and the provider. We need to reauthorize programs such as community health centers, teaching health centers, graduate medical education, children's hospital graduate medical education, and we need to do this quickly, and we need to do it in a way which is fiscally prudent. I will say that both Republicans and Democrats believe these issues need to be addressed in a bipartisan fashion. So as a ranking member, I'm committed to working with my Democratic colleagues, my Republican colleagues, to find solutions which bolster healthcare workforce so that our healthcare workforce can provide critical care, the absolute care which is needed in communities in Louisiana and other states. As always, if there's any other way my office can be helpful, please call.
So let's take a 10-minute break, and we'll come back with our first panel, and we'll continue this conversation about workforce issues for health. Thank you.